Okay, abdomen and pelvic protocols. So if we first begin with the liver, we'll look at basically what comprises liver function. Because the liver has a dual blood supply, the hepatic artery and the portal vein, there are several phases of enhancement after the IV administration of bolus of contrast. So we're going to be looking for several different phases. And phases to know are the hepatic arterial phase, or the HAP, the portal venous phase, or the PVP, and the equilibrium phase, where things kind of balance out. So these are some of the phases that potentially you'll be looking at in terms of CT of the liver. Because a helical CT scan is completed within a very short scanning interval, a uniphasic injection using a relatively rapid injection rate, which is around 3 to 5 milliliters per second, is most advantageous. So basically what we're looking for is rapid injection rate. Remember, 3 to 4 usually doesn't quantify as rapid. Usually is around moderate, but 5 would be very much rapid. So somewhere in the 3 to 5 range is where you're going to be injecting. For most IV contrast injection protocols, a scan delay of 60 to 80 seconds is appropriate. So keep that in mind, 60 to 80 seconds. At very rapid rates, such as 5 milliliters per second, a delay of 50 to 60 seconds may be employed. Because of the speed of helical CT, one may scan the liver during either the HAP or the hepatic arterial phase, or the PVP, which is the portal venous phase of enhancement, or during both phases. With the older scanners, this was not possible to actually get both phases because it would take so long to actually acquire one phase that you'd be almost ready to enter into another phase. But now that has changed. Because most metastases are hypovascular, and it's important that we understand what hypovascular means. It means that low blood supply is typically what we're seeing. Hypo means low, vascular means basically blood supply, so low blood supply. Compared with normal hepatic parenchyma, when imaged during the PVP of enhancement, conventional dynamic incremental hepatic CT scanning protocols were designed to optimize imaging during this phase of contrast enhancement. So basically, what this huge paragraph is saying is that basically we've developed protocols so that we can best demonstrate liver mets because of them being hypovascular. One thing to keep in mind, though, is this next bullet point, which tells us that primary hepatic neoplasms are usually isovascular or hypervascular. So iso means same, and hyper means greater. And so usually primary hepatic neoplasms are going to look the same or even be more defined and are better imaged during the arterial phase of the hepatic enhancement. So because they have this great blood supply, typically you're going to want to image them in the arterial. Typically you're going to want to image them in the arterial phase of the hepatic enhancement. If the desired arterial phase scan is the desired arterial phase scan usually begins around 25 to 30 seconds after initiation of the contrast injection, although there is considerable variability from one patient to another. So we need to keep this in mind. 20 to 30 seconds usually will get the job done. However, every patient varies. And that's something that you're always going to see in CT. What works for one patient usually may not work for another patient. And so because of that and this variability, sometimes things just don't necessarily work the way that we want them to. Studies of patients with hepatocellular carcinoma and various types of hypervascular metastasis, such as endocrine tumors, renal cell carcinoma, melanoma, thyroid cancer, carcinoid, and other particularly endocrine tumors, have demonstrated an 8 to 14% increase in lesion detection with dual-phase HCT compared with just PVP imaging alone. And so keep this in mind, this 8 to 14% number, thanks to dual phase. And so that's why dual phase has gained quite a bit of prominence based on new CT technology. The pancreas. Much like the liver, there's 3 phases of pancreatic parenchymal enhancement. One is the arterial phase, which begins 20 to 40 seconds after initiation of injection. Pancreatic or parenchymal phase, which is 40 to 60 seconds after injection. And the venous phase, which is 60 to 90 seconds. The important thing to remember, based on the way that these phases actually work, no study to date has evaluated all 3 phases in the same patient. It's kind of impossible if you look at the turnaround time, 20 to 40 seconds. By the time that you get this scan done, you'd be ready to enter into this scan, and by the time you got this one done, you would enter into the third. And so it'd almost be impossible to actually perform. 2D rendering using curved MPRs and 3D rendering using maximum intensity. 2D rendering using curved MPRs and 3D rendering using maximum intensity projection, shaded surface display, or volumetric rendering technique, such as VRT, may be useful in demonstrating this area. So to compensate for the inability to demonstrate all 3 phases, we can utilize reconstructions here. Because islet cell tumors are typically hypervascular, they should be more conspicuous during the early phases of dual phase pancreatic HCT. Thus, the arterial and parenchymal phases may be complementary, and both phases may be necessary to fully evaluate patients with suspected islet cell tumors. If you have islet cell tumor, then typically you're going to want to do both arterial and parenchymal phases, which, as they are back to back, may be actually hard to do, but studies have demonstrated that to fully evaluate islet cell tumors, both phases should be attempted to be acquired. So that brings us to the kidneys. This is one of the most common things that you're actually going to be scanning. People have abnormalities with the kidneys. You're going to see people come in complaining of lower back pain with a history of renal stones. You're going to see patients come in with maybe elevated blood pressure or low blood pressure, or orthostatic hypertension or hypotension. Things like this are all going to be possible reasons for you to scan the kidneys. And so, with that being said, with helical CT, the kidneys are typically scanned with 5 millimeter thick slices during a single breath hold and are reconstructed at 5 millimeter intervals. I actually disagree with what the book says here, because we still use fins. The problem with doing 5 millimeter thick intervals is, once again, the step pyramid type image. You get an image that looks similar to this, and you have differing points of anatomy, and so you can actually see the steps. And so typically what we do is we scan patients even on the abdomen or just abdomen pelvis without. We usually scan them with fins and then reconstruct from fins at 5 millimeter intervals, so that you can still do your MPRs and all of your 3D reconstructions if you so choose. Overlapping reconstructions can be performed when needed. This is a very important point here that we're putting a star by. CT performed without IV contrast material is a suitable substitute for IV urography in many patients with acute flank pain. And so gone kind of are the days when ER physicians, for patients who would be coming in with lower back pain and having all the symptoms of some abnormality with kidneys, gone are those days when they order IVPs. And so now we have actually changed to CT, just simply without contrast. Direct visualization of renal or ureteral calculi and secondary signs of stone disease such as hydronephrosis, hydroureter, and perinephrine soft tissue infiltration may be seen in patients with acute renal polyp. And although the X-ray dose associated with helical CT examination, particularly on a multi-slide scanner, is greater than that with a tailored IV urogram, the HCT examination is performed much more quickly, and dose does not require IV contrast. This is supposed to be does not dose. Okay, but the thing that I like to focus on when you're doing a CT of the abdomen pelvis and you're solely looking for kidneys, typically, even though the patient may be experiencing signs and symptoms that kind of lead you to the kidneys, there's no guarantee that everything is a result of the kidneys. So if the patient is in severe pain, that's why abdomen pelvises without are such an integral part now of medicine, because you can get the patient on the table, get the patient scanned, and the patient back to the room in usually under 10 minutes. 10 minutes is usually a very lengthy amount of time. Usually you can go in and out pretty quick. And because of this, you can actually see any other things that might be causing this patient some abnormalities as well. What if the patient is having right flank pain and they do have a history of renal stones, but they're running a fever and all of this, and so you take them, and if you only did an IV urogram, then you're only going to be looking for the kidneys. But what if when you're scanning the patient with an abdomen pelvis without contrast, you actually see that they have an inflamed appendix, and so that was causing the right flank pain. And so because of that, you saw something else when you were looking solely for the kidneys. And so being able to see other causation factors, that's what makes and then causes CT to be employed as great as what it is, just because it aids in diagnosis so vastly. So general comments: respiration should be suspended anytime that you're doing an abdomen pelvis. However, we know that not everybody can suspend their respiration, and so quiet breathing is tolerable when scanning the pelvis only. Prolonged breath holding can be facilitated by preliminary coaching and hyperventilating the patient with 3 or 4 deep breaths in rapid succession just before beginning the HCT or the helical CT. I've never actually tried the hyperventilation technique because usually my patients are one of 2 types. Either they're excellent and they're in good enough shape to actually hold their breath, or they're incapacitated to the point where there is no way that I can get them to do anything. And so I've never actually tried the hyperventilation technique. It'd be interesting to see if it actually works. Usually what I tell my patients is that basically if for some reason you can't hold your breath for these 20 seconds that we're going to be scanning all of this area, just kind of blow it out real gently and breathe it in real gently. And usually that'll decrease the amount of motion if there is any at all. And so the respiration is one of those big things that not everybody can do, and sometimes that has to be worked around as best you can. And so that brings us to oral contrast. Oral contrast material Abdominal and abdominal pelvic CT patients are given 600 to 800 milliliters of oral contrast material to drink 45 to 60 minutes before their examination, and an additional 200 milliliters just before scanning. However, this 45 minutes to 60 minutes will not allow it sufficient time to actually reach the rectum. That's one of the many things that sometimes we get it wrong. Usually, what I have found to be the best protocol for allowing it to reach the rectum is the way I stagger, way our facility staggers the drinks is they actually have the way our facility actually usually performs our scans is we have 20 milliliters of gastrografin per 600 milliliters of we utilize basically some diet Kool-Aid. It's artificially sweetened so that we can give it to diabetic patients as well. And we pour our 20 milliliters of gastrografin into this. And so we let them drink this, and then we wait 1 hour. Then we do the same protocol again, with the exception of them only drinking 400 milliliters. And then we wait another hour. We bring them down to the scan room, and then they finish off the 200 milliliters. And usually, by this amount of time, usually around 2 hours, the contrast has reached the rectum, or very close to the rectum. I think one of the many things that we kind of get wrong with CT is not allowing the contrast medium to actually get to the rectum. And we kind of overlook this. The reason we need to allow the contrast medium to get to the rectum is quite simple. If you don't allow the contrast medium to get there, there can be some abnormalities such as rectal cancer, things like this, some weird mass down there, or also the patient could have free pelvic fluid if it's a female with a huge cystic mass type deal, and it's essential that you be able to distinguish where the rectum is and where this fluid begins and things like that. So it's essential to get it to the rectum. So you always want the contrast to be in the rectum, the oral contrast. Very, very important here. Another thing to keep in mind is dilute water-soluble contrast may be performed for outpatients to increase bowel motility and promote uniform bowel opacification. Water-soluble contrast material is given to the post-operative post-traumatic patient in whom bowel perforation or leakage is a possibility as well. Basically, I'm in favor of only using the water-soluble contrast. Even though there is a slightly more elevated cost here than what we would see with the barium contrast, I think that in the grand scheme of things, you actually see better results with water soluble. And here's my basis for that. Water soluble does not give you the same risk that dilute barium contrast medium will. Dilute water soluble for just about every patient can take it. There's very few patients that have significant iodine allergies that are not able to utilize gastrografin or whatever your water soluble contrast may be. And also, we are kind of unsure as to what might actually be the case with each patient walking in. The patient may be having just generalized abdominal pain, and they may actually have a ruptured appendix. The last thing you want to do is be or allowing them to basically drink barium. I think back to probably about a year ago, I had a lady come in. She was having severe abdominal pain, First, I shot an abdomen flat and upright, and the abdomen flat and upright, I really couldn't demonstrate anything. There was no abnormality, nothing. And so we decided that we were going to do IV and oral contrast. And so we had both barium and water soluble. However, because this is an ER patient, our protocol is that we use dilute water soluble contrast. And typically that's what we utilize for probably the high majority of our patients. And so I gave this lady some water soluble contrast to drink. She drank it, and actually, when I scanned her, she had a bowel perforation. And so, if I had used dilute barium, it would have made a horrible mess, and it could have gotten nasty very quick. But because water soluble, there was really nothing to be worried about there, because basically it'll just be absorbed back into the patient's body. And so there's a lot less to actually worry about here. On the other hand, dilute barium may be preferred for routine inpatients, largely because of the ease of contrast delivery to the patient floors and to avoid the increase in bowel motility associated with water-soluble agents. That's something that sometimes you'll hear about, sometimes you won't. In terms of water-soluble, sometimes patients say that it almost gives them diarrhea, and other patients tolerate it very well. And so a lot of facilities sometimes favor the dilute barium just simply because of this non-increase in bowel motility, or the decrease in the possibility of there being an increase in bowel motility, I guess you would say. And so it's kind of whatever your facility prefers and whatever the protocol is actually set up for that. Patients may be given a large cup of water to ingest immediately before their abdominal CT scan. This is better tolerated by the patients than another cup of contrast material. It may provide better definition of the wall of the stomach and duodenum, particularly if IV contrast material has been demonstrated. So basically, if you're going to utilize IV contrast, then it wouldn't be unheard of or unthinkable to actually give the patient a large cup of water instead of a large cup of contrast to allow them to drink it and define the stomach a little better. Okay, let's begin by looking at some protocols. As we'll notice, this is our first protocol, and it is a routine abdomen. The really general indication for this is just a screening for abdominal pathology or follow-up. As the name implies, we go back to it being a routine abdomen. And if we'll notice, there's stars here up at the top. So if we go all the way down and look, we notice that we see them here. Here the abdomen is taken to include the pelvis. However, the upper abdomen may be scanned along by itself. And this is actually supposed to be alone. And the range for that is above the diaphragms to the crest. So we kind of modify what we're doing here. You will see probably over the course of your career several orders a week for just a routine abdomen. However, I feel that this is kind of useless because while you've got the patient on the table, why not just scan a few more inches down and actually get the entire pelvis so that you can see any pathology that might exist there. So if we look at the patient position, this is going to be quite common to pretty much every one of the abdomen pelvis CTs. And so let's just write common here. So this is typically what you're going to see, the patient laying flat on their back with their arms elevated above their head. And the reason we do the arms above the head is to decrease scatter or any type of streaking artifacts. That brings us to the anatomical range. As we can see here, this is your scanogram. And as we can see, we have the dome of the diaphragms here. And then we have the iliac crest here, T12 right here, and then we have the symphysis pubis there. And so if we'll notice, we have the red kind of marking where we're actually going to be scanning from. So we're scanning from above the diaphragm to the pubic symphysis, or below the pubic symphysis. One thing that I want you to kind of keep in mind here is notice that we have, to some degree, a lot of kind of useless area here and here. And the reason for this is we want to get all of the soft tissue that we can. So as we go through the hips, we want to be able to get any soft tissue that's overlying here. So we have to widen everything out, and we have to sacrifice some kind of wasted space for the sake of the scan. So you're scanning from above the diaphragm to the pubic symphysis. Key here is this is your scanogram or SIR view. So this is simply designed for planning. The problem with planning is that the breath hold that the patient took in for this might not necessarily be the same breath hold that they're going to take in for the actual scan. So my rule of thumb is I usually always try to go well above the diaphragm, just in case they aren't able to take in as large of a respiration. In a way, I'm still covered there. And then usually females, you stop right after the symphysis pubis. But if you're looking for something like a renal stone or any kind of pathology like that, I usually scan just a little farther down for a male, and so I might end right about here. And the reason for that is I want to be able to get the urethra. Remember that males have a longer urethra than females do, so while a female, you're actually going to get pretty much all of the urethra by just scanning down towards the symphysis pubis. Males, you're not going to be able to do that. So I actually like to scan down so you can see the urethra almost in its entirety. And that's something that the books will not tell you to do. But it's a strategy that I've employed, and I've actually caught a couple of stones being passed through the urethra like that in a patient who's been having symptoms of renal stones. So it's just something to keep in mind. As we've already covered, patient respiratory instructions are going to be breath hold in or on inspiration. That just allows us to get the diaphragms more along the lines of what we see in the above image. Contrast enhancement is going to be 120 milliliters at 3 milliliters per second, which is still kind of a lot. In all actuality, I usually inject, our protocol is we inject 85 milliliters. And usually we're injecting at 2.5. But the book says this, so for your quiz or test, this will be the number that you go by, because that is what the book says. But one thing to keep in mind as you get into the field and you go into different facilities, you'll see that there are different degrees of enhancement and what people feel is the best possible approach, and your book tends to favor this approach. Also, 65-second delay, which seems quite a lot. Our delay usually is about 55 seconds. And if you'll notice here, there is no other scan. It's just one scan. So this scan is typically going for the arterial phase for the most part. So typically you're going to see though that usually there is a delayed phase, which usually runs about 5 to 7 minutes to get the kidneys being starting to excrete the contrast down the ureter and things like that. But once again, all we're going to know is what the book tells us right now. So just go by the book. Collimation is going to be pretty much the same, 64 by 0.6. So this means that you're getting 64 slices at 0.6 millimeters in thickness. And so you recon those from there. Pitch is going to be 1. And once again, we refer back here that while this says just a routine abdomen, abdomen in this book is taken to mean abdomen and pelvis. And so you can, if the order pops up, if the order comes up on your screen, then it's typically going to be just CT abdomen, and that's going to mean that you only scan the abdomen. And so once again, you go to above the diaphragm to the iliac crest, and that is going to comprise an abdomen. Okay, so that brings us to a biphasic abdomen and liver. And so this means biphasic. Bi means 2. And so there's going to be 2 phases here. And so if we look at the indications, this is for possible hypervascular. So keep that in mind, hypervascular liver metastasis, such as carcinoma, melanoma, endocrine, pancreas, hepatocellular carcinoma, adenoma, and focal nodular hyperplasia. And so basically, it's going to want to point out a hypervascular lesion in the liver. And so that's typically what you're doing this for. So if we begin, the patient is going to be laying supine with arms elevated above their head, much like we just saw with the routine abdomen. And you're actually going to be scanning on this from above the diaphragm, which once again is here and here. And so you always go with your higher diaphragm. So it is, in this case, on the right side of the patient. And then you scan down to the iliac crest to comprise a complete biphasic liver or abdomen. And the reason that we scan down, if you're only looking for the liver, but you scan all the way down to the iliac crest, there's many times when patients have liver disease, they can have hepatomegaly, which will mean that the liver sometimes will go all the way down and look something like this. And so if you were to scan only to about, here's 5, 4, 3, if you were to scan to only 3, you would miss this lower portion of the liver. So it's very important that you scan down to the iliac crest in this regard. Once again, open up your scanning field so that you're actually getting all the soft tissue here and not compromising anything. Once again, a patient is going to hold their breath at inspiration, and the scan shouldn't take very long at all. If we'll notice something strange here is that we're actually injecting at 120 milliliters, which was the same for the routine abdomen, at 3 milliliters per second. And so sometimes you'll see this bumped up actually to around 4 milliliters per second, depending on what your facility believes, a high flow rate, lower amount injected, or low flow rate and a higher amount injected. But that's neither here nor there. The image timing is going to be about 35 seconds for the first scan and 65 seconds. So remember that there are 2 scans here, and they're both going to mirror what we just saw. They're both going to mirror this scan, and so you're going to have 2 scans here that mirror this. Collimation, once again, they're performing this on a 64 slice machine, and they're doing this at 0.6 millimeter slice thickness, and then they're reconning this up. Pitch is going to be 1, And in our comments section, there was a few comments that I thought we should actually look at. MPRs, or multiplanar reconstructions, are useful, especially if surgical segmentation or resection is planned. So in the case of surgery, MPRs could become invaluable. So always do MPRs if you can, but also try and demonstrate anatomy as best you can as well. MIPs, or maximum intensity projections, are useful for hepatic vascular studies, and the reason they're useful is because we're looking for vascular abnormalities, and so it kind of makes all the vasculature kind of stand out away from all the other structures. So that brings us to a triphasic abdomen or liver. Bi means two, so this means that we have three phases that we're going to actually be looking. Indications here, or the reasons that we're actually going to be doing this study, is characterization of lesions such as a hemangioma. Patient position is much the same, supine with arms elevated above the head. Once again, anatomical range from the diaphragms to the iliac crest. And so that's going to be your scanning range. Breath hold is virtually the same. Breath hold in inspiration. Even the contrast enhancement phase is the same as the biphasic and the routine abdomen. And so all of this is the same up until this point. And so the only difference that you need to remember from the triphasic and the biphasic is your first two scans are going to be the same. 35 seconds and 65 seconds is where you want to hit your scans around. But then we add an additional third scan. So write on your paper, or make a note that you're doing 3 phases. And then you're going to have three scans here. Collimation is virtually the same. 64 slices at 0.6 millimeters in thickness. Pitch once again is 1. So virtually everything is the same as the biphasic, with the exception of an additional third scan. Comments here. Hemangioma exhibits dense peripheral nodular enhancement, filling in towards the center, perhaps leaving a central unfilled region. And so basically there could be a central unfilled region to the hemangioma, and that's what kind of makes it have the ability to be diagnosed as a hemangioma, just basically because of the representation of how it actually appears in terms of CT. So basically the thing to keep in mind here is that biphasic has scans at 35 seconds and 65 seconds. Triphasic, on the other hand, scans at 35, 65, and 120 seconds. And so, as the name implies, there's 3 phases here. Okay, CT arterioportography, and it is preoperative. That is a key word here. It's for pre-op, and it's for the detection of liver lesions. And so you perform this supine with arms elevated above the head once again, from the diaphragm to the iliac crest, so that you make sure that you get all of the liver. And so you want to make sure that you get the entire liver if you're looking for lesions. Respiratory instructions, once again, patient to hold their breath at inspiration. If we'll notice though, it's a little different. A contrast enhancement is going to be 60 milliliters at 3 milliliters per second into superior mesenteric artery. So the patient is going to have a catheter already placed, and then basically you inject that into this area. And so you want to keep this in mind. Catheter is already placed. You're not going to be sitting here having to figure out where the SMA is and then stick a needle down and hit the SMA and all this. You're not going to have to worry about that. The patient's already going to have this catheter placed, and this is just simply so that they can plan the surgery out a little better. And because of this, you're injecting into the superior mesenteric artery. We see that we scan a little faster here, 30 seconds, and then we scan another at 90 seconds. So basically, you're looking at half a minute and then a minute and a half that you're actually scanning. Collimation is 64 by 0.6. Pitch is 1. And then we see in the comments, the injection may also be into the splenic artery. 2 phases are necessary since there are frequently perfusion defects in the early phases. NPRs may be useful, but I would highly doubt that this would be a scan that you actually do very often at all. So just know that the catheter is already placed, and this is not something that you have to worry about. Thing to keep in mind is just when you're going to be scanning your 30 and 90 seconds. Because you definitely have to have your 2 phases, and that's going to get them 30 and 90 seconds. And then, just in reconstructions, check out your MPRs and see if you can manipulate them into something that is actually of a higher diagnostic quality than what you traditionally might have just acquired with your axial scan. So if you can aid in the diagnosis. Okay, so that brings us to CT hepatic arteriography, which is for vascular liver lesions. And so we're looking for things that are on a vascular level, highly vascular. And so we'll see that it shares a great deal of things with arterioportography. The patient's going to be positioned supine with arms elevated above their head. And we're going to be scanning once again from the diaphragm to the iliac crest. The patient is going to hold their breath in inspiration. So all of that is the same as what we've been talking about and discussing. The real difference here is the contrast enhancement. Notice we're injecting 30 milliliters at 2 milliliters per second. And so roughly you're taking 15 seconds for your injection. And with about 5 seconds left, or 10 milliliters left to inject, you scan. So a 10-second delay from the time that you actually start to allow you to actually get 20 milliliters in, and then you scan the patient. Collimation, once again, 64 by 0.6. Pitch is 1. However, if we'll notice in our comments, this technique is no longer frequently used, and so you may never see this technique. So just know that this technique exists, but you don't have to know a whole lot about it. The biggest thing is just your contrast enhancement, where and why you're injecting this. Okay, that brings us to something that is slightly more common, pancreas. We all know that the pancreas can cause significant abnormalities and can really be a very bad thing to have any abnormalities actually happen if you're a patient. And one of the big things about it is pancreatitis. If you have inflammation of the pancreas, then it can sometimes turn quite deadly. And so, depending on how it's actually treated, will adversely affect or increase the chances of the patient surviving or not surviving. And so, many times, just a pancreas study is going to be used for diagnosis of pancreatitis and/or follow-up. And so, many times we see this is just defined as pancreatitis follow-up, but keep in mind that it can be utilized for pancreatitis as well, just to aid in diagnosis. So the patient is once again going to be situated at supine with their arms elevated above their head. And the anatomical range here is going to be above the diaphragm to below the uncinate process. And the problem being here, where exactly is the uncinate process? If we go by what we're seeing on the scanogram, we've got L5, 4, 3, 2, 1, T12, T11, 10, 9, and then we've got 8 situated right up here. Usually, it's an accepted fact that the head of the pancreas sometimes lies around L2. And so, with the body situated slightly above. However, the uncinate process is around the head of the pancreas, and so around the level of the head of the pancreas. And so if we take that into an accepted fact, then we have to at least scan to L2. Usually you can scan to L3, and you could say that that would be safe, but my thoughts here are scanning down to the iliac crest, simply because you would rather not take a chance on missing this, and what's it going to hurt to scan just a few more inches to be sure that you actually get this. It's better to do it correctly once than do it multiple times because you've done it incorrectly. And so I always err on the side of caution because you don't actually know where the patient's pancreas is located. I'm in favor of utilizing a larger margin here. But keep this in mind that your book says above the diaphragm to below the uncinate process. So that's what you need to know for your quiz and test. Patient respiratory instructions, breath hold, and inspiration, once again very much the same. Contrast enhancement, we're only utilizing 100 milliliters at 3 milliliters per second. And we're scanning at a 65-second delay. If you'll notice, this is almost the same as what the book says for a routine abdomen. And so, pretty much there's not that much variance between your routine abdomen and your pancreatic study. Collimation is 64 by 0.6 millimeters. Pitch is 1. Then the really interesting thing here is that water as an oral contrast agent is preferred. And you may also put the patient right side down before scan to actually feel the duodenal loop. So basically, give the patient some water before you actually scan the patient, and then put them on the right side for just a few minutes so that it feels the duodenal loop, and then you lay them flat on their back. The reason we don't typically want oral contrast utilized here is because that oral contrast has a tendency and a propensity to actually cause streak artifacts if it's done in a higher density than what is actually needed. And so you definitely don't want to obscure data or obscure pathology by utilizing oral contrast. So typically it's better to err on the side of caution and only utilize water because of the decrease in the amount. So if we're looking for something other than pancreatitis or follow-up to pancreatitis, such as a pancreatic tumor or wanting to stage a tumor, then we can actually do a different study. As we see, the indications are pancreatic tumor detection and or staging. So patient is having symptoms of something going seriously wrong with the pancreas, such as a mass, and so you want to see if there is one, or you want to stage it if you already know it exists. And so the patient is going to be situated with being supine, with arms elevated above their head, and we actually have two scans here. Kind of confusing actually as to why they perform this like this. First scan is going to be above the diaphragm to below the insonate process, so you're scanning around L2 to L3. Second scan is going to be the whole upper abdomen to cover the liver. So you're worried about covering the liver, so typically you're going to go down to the crest. And so here we see that we have 5, 4, 3. We're scanning down to L3, and we're going from the diaphragm to L3. This one we're going from the diaphragm down to the iliac crest, so that we can be certain that we actually get all of the liver margin. So this one you're looking for pancreas, and this one is more concerned with the liver. So phase 1 is more pancreas. Phase 2 is more along the lines of liver. Patient respiratory instructions, once again, is breath hold and inspiration. Contrast enhancement is going to be 100 milliliters at 3 milliliters per second. And so you're looking at around 33 seconds to actually inject all of this. And so almost as soon as your injection gets done, you scan, and then you wait 65 seconds, scan again. And typically your first scan is going to be phase 1, second scan is going to be phase 2. However, I am of the mindset that if it was me and I was scanning, I would scan on the first scan all the way down to the iliac crest, and the second scan to mirror that too. However, it's depending on whatever your facility's protocol actually is. That's why it is such a difficult thing to kind of discern and nail down what protocols are, because each facility kind of does them a little differently. But for me, it seems to make a greater deal of sense to actually scan down to the iliac crest, so that you can be sure that you get the liver in biphasic as well as the pancreas as well. Once again, collimation and your pitch are the same as we've actually looked at. In the comment section, though, we see that we're actually going to scan the patient 3 times. You're going to have one serve view, one scan to be unenhanced, to locate the pancreas. Second scan is going to be at 35 seconds to do phase 1, and then at 65 seconds you're going to perform phase 2. And so that's why I'm in favor of utilizing phase scanning down to the iliac crest on phase 1 and phase 2, because you eliminate this unnecessary unenhanced scan. But that's just me. Water as oral contrast agents, once again, are preferred. Put the patient right side down to fill up the duodenal loop, and then lay them flat on their back. Also, early and late arterial phases may be useful. Just because the image timing is at 65 seconds does not necessarily mean that 65 seconds may be the only time that you scan. Depending on what your protocols are in your department, you may actually scan for another time, such as like 120 seconds or something to the effect of 3 or 4 minutes, simply to see how the enhancement actually progresses, so that you can better demonstrate this area. Also, CT angiography is essential in tumor staging, and so this may actually require other studies as well. But this is to be helpful in staging a tumor or detecting the presence. And so just keep this in mind, that every department's going to kind of be a little different in terms of. So that brings us to the renal system. The indication for this is a follow-up of a renal tumor, inflammation, or infarct. And so pretty much anything that could possibly be involving the renal system. The patient is going to be supine with arms elevated above the head, and the anatomical range is going to be from mid-liver to mid-pelvis. Exactly what is mid-liver is going to be kind of up to each and every person's differentiation. Here is the diaphragm. So the liver is going to be somewhere around this area, and the liver may extend down this area. So this is slightly above mid-liver, so mid-liver would be around here. The important thing to really understand, though, is that the kidneys usually are situated somewhere. Here's 5, 4, 3, 2, 1, 12, 11, let's say 10 here. The kidneys are going to be situated somewhere in this area here. And so remember, your left kidney is going to be slightly higher than your right kidney due to the liver. And so your left kidney is going to usually be around T12. Right kidney may be around T1. Usually they extend down to T2, T3. Some are not T2, T3, but L2, L3. But you definitely want to be able to get all of your renal system on this in terms of the kidneys and the upper portion of the ureters. And so the ureters are going to be running down, doing something like that. And so you're going to go to mid-pelvis. You can actually get to right above the acetabulum and still be pretty much in the abdomen cavity. But notice that this is really not bound by these type of rules. So you're actually scanning from this area. The respiratory instructions, once again, is breath hold at inspiration, 100 milliliters at 3 milliliters per second, taking roughly around 33 to 34 seconds to actually carry it out for the contrast. And so after your contrast injection is completed, around 40 seconds is when you're actually going to scan. So you're going to have an overlap of around 5 to 6 seconds, and then the scan will commence. And the collimation is going to be about 64 by 0.6 millimeters, and the pitch is going to be 1. Notice, though, that we don't have an actual excretion phase. In terms of this, we're only scanning for arterial. Because if we go back up and we look, we see that this is for a renal tumor or infarct and inflammation. So we're not concerned with the excretion factor. We're concerned with what this actually looks like if there's a mass there. And so that brings us to the fact that NPRs are very useful. Manipulating, turning into an oblique so that you can better differentiate kidneys is very important. Also, if renal artery stenosis is suspected, use water as oral contrast agent and reconstruct CT angiograms. So basically, utilize this water contrast to actually kind of differentiate certain parts of the bowel and kind of reconstruct it using NPRs. Also, to exclude renal vein and inferior vena cava from thrombus, extend the scan up to the right atrium. And so if you're worried about the inferior vena cava and the renal vein, then extend all the way up to the right atrium. And so if we go back up to our image, the right atrium would be situated right here. And so basically you could scan from above the diaphragms on down. And so that would be something that you could actually get. The book is kind of contradictory in a lot of ways, because it tells you that if you're looking for this, then scan on up. But many times we don't actually know what physicians are looking for. So who's to say that this wouldn't be a good idea just to go all the way up to the diaphragm and scan down? But once again, we're going by what the book says. And we're looking at the anatomical range from mid-lip. So this scan is once again for the renal system, and to aid in detecting tumors and to provide a differential diagnosis. And so something that might be actually existing other than a cancerous lesion. And so that basically brings us to the indication, which is a differential diagnosis of renal masses. A patient is going to be supine with arms elevated above the head, and the anatomical range is going to be from mid-liver to mid-pelvis. So if we'll notice, it's virtually the same as the scan that we just previously looked at. Breath hold is going to be in the inspiration, and even the contrast enhancement is going to be 3 milliliters per second, and you're going to be injecting 100 milliliters. The way that we kind of differentiate this is, if you'll remember, our first scan was going to be at 40 seconds for the previous one that we were actually looking at, which is the arterial or corticomedullary phase. And so basically you're seeing the arterial enhancement of the kidneys. However, this actually adds two other phases, so that you're scanning 3 phases. So you're looking at 3 phases here. The second scan is going to be accomplished at 90 seconds, which is the nephrographic phase. And then 240 seconds, which is the excretory phase. So basically you're looking at 1.5 minutes. And then you're looking at 4 minutes to actually get the excretory phase. The thing about the excretory phase is, if you want to go a little longer, sometimes you can go 5 to 6 minutes to hit the excretory phase, and it'll still be applicable. So there's 3 scans here, and that's typically what you're wanting to think about. Collimation is going to be the same, 64 by 0.6. Pitch is still going to be 1. The comments, we need to look at the first one. This triple phase scan is useful for differential diagnosis of renal lesions, particularly tumors, but is relatively a high dose procedure. The excretory phase is useful for suspected renal pelvic mass. The thing that I would say is, in response to this high dose procedure, that you could actually probably rule out this 90-second nephrographic phase if you absolutely had to, so that you could see the excretory phase, which would still aid in the diagnosis of a renal pelvic mass. And so typically, if you were going to choose to eliminate one, the 90 seconds would be the one that you would eliminate. But the thing to argue about the high dose, every exam that we do in CT is going to be considered high dose in comparison to just conventional radiography. But the thing that you have to consider is the benefits outweighing the risk? Are we getting more than what we are actually giving? So are we gaining more information from this than the dosage that we're actually giving? So if we view it in that respect and say that it's more beneficial to the patient, then all of a sudden things start kind of lining up and coming into perspective. That okay, here is a scan specifically for the adrenal glands, and the reason for this is if you're clinically suspecting an adrenal tumor, or if you do see that you have an adrenal tumor and you're wanting to characterize what type it is. That would be the reason for this scan. Once again, the patient is supine, arms elevated above the head. So the anatomical range is kind of confusing based on what the book says. The adrenals, which is kind of leaving everything up in the air. If we assume that the kidneys begin at T12, which this is 5, 4, we can see the rib coming off the 12th vertebrae here for T12. So if we say that the kidneys are situated here and the right kidney is slightly lower, we're going to say that the adrenal is somewhere around this area. And so we need to at least scan T11, possibly even go up to T10. So somewhere around the vicinity of T10 to let's say around L2 or L3 should get you where the adrenals are. So that's something to keep in mind, so that it's not so ambiguous such as adrenals. So in this case, go by this number here to hopefully get you in the ballpark of the adrenals. Respiratory instructions are much the same. Hold in at inspiration. And so basically what this is going to argue is that there's a pre-contrast agent infusion scan series first. And so basically you need to scan the patient before and so basically you're going to do a without scan and then you're going to do a with scan in terms of the adrenals. So that's what it's meaning here. And so you do your without, and hopefully that'll allow you to plan everything out and get in the right margins for the adrenals. And then when you're doing the contrast enhancement, you're doing 120 milliliters at 3 milliliters per second, which is equivalent to 40 seconds for a total injection. So 10 seconds after the total injection is stopped, then you're actually going to begin the scan. And so you're going to hit it, and it's going to be in arterial phase to actually enhance. Pitch is going to be 1 and collimation is going to be 64 by 0.6. The real key to keep in mind here is the contrast enhancement in the image time, so that you can be pretty certain that you're actually getting the patient scan in an adequate fashion. And do not forget that you're scanning the patient without first, so that you can kind of aid in the diagnostic process, so that you can differentiate what is enhanced from what is just normal. And then you can also aid in planning out your scan. Okay, this is a CT pneumocolon. It's for the detection of large bowel tumors and or polyps. And so the patient is going to be positioned, arms elevated, supine, anatomical range. This is what we typically think of as being an abdomen pelvis in its entirety, scanning from above the diaphragms to below the pubic symphysis. And so you're comprising all of this area here. You're getting all of the bowel in its entirety. Patient respiratory instructions are breath hold and inspiration. And your injection rate is going to be 120 milliliters at 3 milliliters per second, totaling 40 seconds for injection. The delay is going to come 65 seconds after the initial beginning of injection. So about 25 seconds after you have stopped injecting, you're going to actually begin scanning the patient. I notice this is only one run through. Not any other delayed scans or anything. It's just at your 65 second scanning the patient and then the exam will be completed. Collimation is going to be 64 by 0.6 millimeters, and the pitch is going to be 1. We definitely have to look at the comments. You might want to make a star by the first one. The book recommends scanning caudad to cephalad, and so basically what you're scanning is, in terms of looking at this scan, most of our scans are accomplished like this, going down. Your arrow will be going down, and so you're scanning from the diaphragms down to this pubic symphysis. However, the scanning protocols in this book, in terms of this specific exam, recommend scanning from the pubic symphysis up to the diaphragms. Also, check sufficient air insufflations using scanogram, and you might actually have to repeat with the patient prone. MPRs are useful, and virtual colonoscopy is desirable. The liver is automatically included in the appropriate portal phase, and so based on you scanning at 65 seconds, you don't have to worry about the liver being out of phase or needing to scan at a certain time, because that's took into consideration here. Scan is that when we're speaking of air insufflations, we're speaking of air in colon. The thing that makes really virtual colonoscopy, endoscopy, colonoscopy, things like that work is that you have to have air inside the colon to actually inflate it. So you're not looking for oral contrast. But you're looking for something different. You're looking for rectal contrast. And not any type of rectal contrast, but you're looking for air. And so you're wanting to induce air using an enema tip to actually induce air into the colon. And this is going to inflate the colon to the point to where it allows you to demonstrate polyps and certain pathologies. So the key to this is utilizing rectal contrast, and that's why you have to check if you have sufficient air insufflations using a scanogram. So basically the way it's going to work is the patient's going to be positioned prone or on their side, first on their side with the enema tip inserted into the rectum, and then the patient should probably lay prone to allow air insufflation to occur, and then once sufficient air insufflation has occurred, then the enema tip can be removed and then the patient will be flipped supine to scan. So an important thing to remember is you're not using oral contrast, and you're not actually using iodinated or barium contrast, but you're using air. That is what you need. CT enterocolitis. Evaluation of small bowel or inflammatory process, infiltration, primary and metastatic disease. So all of this is going to be included here. The patient is going to be positioned supine, arms elevated above their head. Anatomical range, once again, is from the diaphragm to the pubic symphysis. Patient respiratory instructions are going to be breath hold in inspiration. Injection is going to be 120 milliliters at 3 milliliters per second. And so this is going to be 40 seconds for the injection. Enema chiming is going to be begun at 60 seconds after the initial starting of the injection. Collimation is going to be 64 by 0. Okay, the comments section for the book just suggests that NPRs may be helpful. However, there are a few things that the book kind of leaves out. Enterocolitis basically is a situation where an NG tube is placed through the patient's nose and goes down to the duodenum or in the upper portion or middle portion of the stomach, and contrast is infused, oral contrast is infused there, and basically allows us to demonstrate what or how well patients' interluminal feeling and function of the intestines actually are. And it's really to aid in diagnosis of Crohn's disease, things like this. So all of this has to be accomplished outside of the CT suite. And so typically, departments kind of do this, once again, a little differently. But many times the NG tube is inserted and routine radiographs are actually taken to monitor how the patient is progressing through the injection of this contrast or the oral contrast through the NG tube. And then once filling has commenced and has actually occurred to an appropriate level, the patient is then taken to the CT suite, and this is carried out. The contrast enhancement, the IV contrast enhancement, things like that are carried out. So there is actually more to this exam than what the book actually allows you to see. But it's one of those things that's not going to be something that you do on a daily basis. Probably won't really become a routine to you because you may or may not ever see this actually performed. However, CT enterocolitis is actually starting to take some precedence away from just typical colitis examinations. Okay, in a trauma situation, CT is excellent in terms of this. Typically, this is done to exclude or detect soft tissue or bony injuries following trauma. Excellent during wrecks, things like that, so that you can actually visualize what is going on in the patient. The patient's going to be positioned supine, arms elevated above the head, which may not be able to be accomplished. Put a star beside this because not every trauma patient will be able to elevate their arms, especially if they've got fractures in those areas as well. So it may be difficult if they can't do it. Just try and get their arms to their side as much as you can and commence the scanning. The anatomical range is going to be head to toe, which is slightly a little longer than what I would actually consider. Many times, based on the type of algorithms that need to be utilized, scans will be grouped into smaller segments. But in theory, it can be performed in terms of CT now, head to toe. But basically, if you had an order come off for chest, abdomen, pelvis CT for trauma, then you would scan from the upper, from the lung apices down to the symphysis pubis. Things like that would also be applicable. The breath hold instructions or the respiratory instructions are kind of up in the air. There's none if the patient is unable to cooperate. Many times in trauma, the patient is either completely uncognitively aware, or the patient is aware but they are so shaken up by the trauma that they are just breathing rapidly, they're hyperventilating themselves, and so because of that, many times the breath hold is really unapplicable here. You just have to get what you can. A contrast enhancement, ideally, it's going to be 120 milliliters at 3 milliliters per second, but it may be abandoned in cases needing very urgent assessment. Usually in trauma cases, this is what happens. There's no time for contrast to make sure that the renal function and everything is all right before we inject the contrast. We typically would just roll through with just no contrast and see if there's any immediate danger, and then if there isn't, then you can always follow up with contrast later in the affected area. If contrast is given, though, it's going to be timed at 65-second delay. So basically, you're going to scan 25 seconds later. Collimation is going to be 64 by 0.6 millimeters. Pitch is going to be actually 1.5. And we know that this can actually be done with 64 slice scanner in a little over 15 seconds with rotation time of 0.375 seconds. So for short rotation times, we can actually decrease the amount of scanning time that's needed. You may need to tailor examination to particular regions of high suspicion. That goes back to the bone algorithms and things, sharpness algorithms that may need to be applied to certain areas, and so typically head-to-toe mining will actually work. So you may have to modify certain portions of the exam to fit your patient. mp4s are really useful. You can oblique, we all know this, you can oblique things. You can actually visualize certain points of anatomy better just by simply rotating the patient or coming at it at a curved angle, things like that. So you can really differentiate whether something is fractured or not. That's why a CT for trauma has really taken the wind out of the sails for just conventional radiography. It's just so much easier to get them to the CT suite, scan them in a quick amount of time, and then basically get them back to where they can receive treatment. Bone and soft tissue windows are necessary. You want bone windows definitely, but you also want soft tissue windows because they can be an indication of maybe something else going on where the actual trauma has hit. If anything is abnormal in that sense as well. Also, you may need to do an arterial. Okay, now we get into some scans that aren't actually inside your book that I found in others, and it kind of goes into a little more depth. This is an abdominal survey, which is similar to what the routine abdomen was, and this is for screening to rule out METs and to evaluate the liver function. KDP is going to be 120 to 140, somewhere in this range. AMA is going to be 210 to 300. Oral contrast is going to be 600 to 800 milliliters, 45 to 60 minutes before study initiation, and then shortly before study initiation commences, an additional 200 milliliters is given. Once again, the phase of respiration is going to be suspended inspiration or expiration. We're going to favor inspiration here over expiration just simply because it's actually better to view the abdomen. And if we do all scans with inspiration, then it kind of normalizes our techniques. Rotation time is going to be 0.5 to 1 second for one rotation of the gantry. The acquisition slice thickness is going to be 2.5 to 3 millimeters. And then if we'll jump down here, we're going to recon in 2.5 to 5 millimeters. So 2.5 is going to be your lowest, and 5 is going to be your highest. Usually we recon in around 5, unless that you see some abnormality or you're requested to go back and actually recon it in a smaller slice thickness. Pitch is going to be somewhere in the vicinity of 0.75 to 1.5. Usually 1 is a pretty good number. 1.5 I have seen sometimes 0.75 is actually applicable as well. Depends on how fast you want coverage and the amount of detail that you want. 0.75 though means that your table is not moving as much as what you're scanning, so you do have some overlap here. And so I typically want to gravitate towards 1 or 1.5. Reconstruction slice thickness we've already talked about. So that brings us to the anatomic coverage, which is the dome of the diaphragms to the iliac crest. Pretty much just what a routine abdomen will be. Remember I said that we go slightly above the diaphragms simply because we're not guaranteed whether the patient can actually breathe in that deeply or breathe in more deeply. So it kind of helps us get all the adjacent anatomy. IV contrast is 125 to 150 at 2 to 3 milliliters per second. This is a low flow rate. High concentration. And so basically, you're injecting more, but you're doing it at a slower rate. And so if you're looking at injecting 2 milliliters per second and you're doing 125 milliliters, basically you're looking at about 62.5 seconds just to get everything injected. So 70 seconds from initiation of injection is not that far-fetched for your scan delay. And also, if there's any question of renal abnormalities, rescan the kidneys after the medullary phase and collecting system opacification. If densely enhancing abnormalities are seen that need to be differentiated from calcifications, then perform also a few delayed cuts. So basically what you can do is you can scan, if you're scanning at 70 seconds, you can scan at probably about 4.5 to 5 minutes to actually get the collecting system opacification. And then if you were to see anything else, then you can scan probably something like a 7-minute scan and kind of stair step it on. But typically, so this is going to kind of be like the previous scan, but this is for abdomen and pelvis. It's an abdomen pelvis survey, and this is for tumor staging, abscess, things like that as well. Your KVP and your MA are the same as the abdomen survey. Oral contrast, I kind of differentiate with this because even at 60 minutes, it's not going to allow you enough time to actually get it down into the rectum. And so I'm favoring more like 120 minutes to actually opacify the rectum, and which is typically what you're looking for, especially if you're looking for tumor staging where there could be some kind of mass in the rectum. Facial respiration is going to be suspended at inspiration or expiration, but we're going to say inspiration to try and keep a sense of normalcy among our patients and a sense of normalcy among our exams. Rotation time, once again, is 0.5 to 1 second, depending on how your machine will actually allow you to change. Some will only allow you to go to 1 second, some will allow you to go down even farther than 0.5. Acquisition slice thickness is 2.5 to 5 millimeters. We gravitate more along the lines of 2.5, so we can do MPRs. Pitch is going to be 0.75 to 1.5. Remember, 0.75 indicates that we have some sense of overlap, and so we're kind of exposing the patient to the same amounts of radiation needlessly. Reconstruction slice thickness or interval for filming is 5 to 7 millimeter. Usually, tend to gravitate more towards 5 because 7 is a huge slice. 5 is usually the happy medium, which you can always recon back down to smaller slice intervals if you have to. The anatomic coverage, once again, is the dome of the diaphragm to the symphysis pubis. So we're going from here to here. And so that compromises everything that we need for this entire area. The IV contrast is much the same. It's 125 to 150 at 2 to 3 milliliters per second. And even our scan delay is going to be 70 seconds. However, frequently when the pelvis is scanned, the bladder has not opacified with contrast material. Usually 70 seconds, you're not even going to see any contrast inside the bladder, and you're still going to be going through the corticomedullary phase for the kidneys. And so, because of that, if you want and seek bladder opacification or ureteral opacification, an additional 5 millimeter scan, and this is supposed to be a scan here, through the bladder may be performed after a 5 to 10 minute delay. And so basically you can leave the patient on the table for an additional 5 minutes and then scan them. And you should actually see the ureters opacified and the bladder opacified as well. Typically what we perform in every facility is slightly different. If you want just bladder opacification, then you usually just go from the iliac crest down, and so you get the bladder in this area. But also, if you're wanting to see all of the ureter, then you can scan once again from the dome of the diaphragm all the way down to the symphysis pubis, so that you actually get all of the ureter in its entirety. And so there's arguments to be made for both cases. But the important thing is, if you want to see the bladder opacified, 5 to 10 minute delay will suffice for that. Also, it's preferable to use 330 MA for patients up to 250. And then if you have a patient that is more than 250 in weight, then you can go up to 400 MA. And so that will help gain better image quality in terms of this. So sometimes it's necessary to modify your MA. Thorax abdomen, which is a kind of combination study, which sometimes is quite prevalent. We see that it's a combined study, and sometimes it's utilized for oncologic surveys or follow-ups. KB stays the same at 120 to 140. The MA, on the other hand, goes up from 210 to 250, and then it tops out at 330. Oral contrast, if needed, will be 600 to 800 milliliters 45 to 60 minutes before study initiation, with an additional 200 milliliters given just before scanning. So this protocol does work. Phase of respiration, once again, is suspended inspiration, so that you can best get the distension of the lungs. Rotation time is much the same at 0.5 to 1 second. The acquisition slice thickness is 2.5 to 5 millimeters, and the filming is much the same, 2.5 to 5 millimeters. The pitch still stays at 0.75 to 1.5, and the anatomic coverage is slightly different. We go from the lung apices, which we're actually even flipping on this area, all the way down to the iliac crest, or slightly below. A contrast medium, if needed, is 150 milliliters at 2 to 3 milliliters per second. Once again, this is high concentration, low flow rate, and the scan delay actually begins 15 to 20 seconds after the initiation of the injection. So if you're injecting at 2 milliliters per second and you've waited 30 seconds, then pretty much you've injected 60 milliliters, and you've still got about 90 milliliters left to inject. However, this will allow you, as you're scanning, because the scan sometimes will drag on a little longer, to actually hit the right phase as you're going into the liver. Okay, so then we lengthen this study out and make it a thorax, abdomen, pelvis. Once again, a KDP and MA pretty much stay the same from the first scan. Oral contrast is something that I think we need to wait about 2 hours to allow it to actually get where we want it to be in terms of the rectum. Also, do not forget to utilize 200 milliliters given just before scanning. we're scanning at suspended inspiration, and it's going to take us about 1 second to get one rotation of the gantry. The acquisition slice thickness is 2.5 to 5 millimeters, and we recon them in this area too. 3 to 5 millimeters is usually a good number, so that you don't get a bombardment of images in terms of packs. That makes the scan totally unreadable. Pitch is going to be 0.75 to 1.5. And this is going to be a very lengthy scan, and that's why I'm in favor of utilizing many times 5 millimeters for filming, because it just makes the scan a little easier to look at in terms of packs. But you're scanning from the diaphragm all the way down to the pubic symphysis. So this is quite a large area to be covering at one specific time. So if we look at the IV contrast, we're typically going to be injecting 125 to 150 milliliters at 2 to 3 milliliters per second. And many times they, depending on what your facility protocol is, they recommend that you do these in separate scans, where you scan the chest all the way down to about mid-liver, from the apices to mid-liver, and then you pick up with your abdomen scan from the diaphragm all the way down to the symphysis pubis. And so you have these two scans. And so that's kind of what this is saying here, is that you scan the chest first, and then you scan the abdomen and pelvis. And so while it's one initial study, you actually have two separate scans. And so they say that 15 to 30 seconds for the chest and 60 to 70 seconds for the abdomen and pelvis. And so we see in the comments that it's recommended starting the chest after 20 to 30 second delay, then pausing the scanner at the dome of the liver until 60 to 70 seconds, at which time the entire abdomen and pelvis is scanned. And so different facilities will tell you to do different things. Some say have two separate scans planned out, and then as soon as one gets done, the other one waits, and then you scan again. While the book kind of tells you to scan it all and plan one scan out, like what we see here. But then when you get to the dome of the diaphragm, right here, or you start seeing the liver come in, pause the scan, and then wait for a few more seconds, and then commence the scan again. It's kind of confusing, but the real key to this is just knowing 60 to 70. Many times we kind of leave out that we can just do a pelvic study because many times it gets kind of lumped in with the abdomen and pelvis. And so the pelvic study is usually used for oncologic staging of prostate, cervical, endometrial, or ovarian cancer. Notice that we're using around the same kV, 120 to 140, but our mass is dropped to 165 to 275. And the reason for this is because when you enter into the pelvic area, while you do have a lot of bone and the bony structure is really difficult to penetrate, most of it is very thin, and so it makes penetration very easy. Oral contrast, typically 600 to 800 milliliters, 45 minutes, 40 to 60 minutes before study initiation. But then, to gain a better look at rectal contrast media or air is optional. You will usually either have to use rectal contrast or use a larger amount of time. So you could wait your 2 hours or perform rectal contrast. And so that's something to keep in mind here. Whatever your facility really recommends. A phase of respiration is usually suspended inspiration or expiration, but keep in mind we don't really have to have the patient completely hold their breath. They can breathe quietly if they have to for the pelvic area. Rotation time is 0.5 to 1 second. Pitch is going to be 0.75 to 1.0. Reconstruction slice thickness, 5 millimeter usually will suffice, but 2 to 3 millimeter is optional for staging of pelvic tumors. So many times your 3 is going to be your best bet if there's pelvic tumors, so that there's better differentiation of associated structures. Whereas 5 kind of makes everything kind of appear blended together. 3s will allow some degree of differentiation. Anatomic coverage, superior iliac crest to the symphysis pubis. That is going to be the area that we scan, but I like going slightly above the iliac crest and slightly below symphysis pubis, just to make sure that if the patient is shifted on the table at any portion, we still actually get the correct anatomical coverage. IV contrast is going to be 100 to 125 milliliters at 2 to 3 milliliters per second, which translates into a delay of 70 to 80 seconds, which is quite a long time. But you have to remember that we're going in a deeper area of the body, and so because of that, we can afford to wait just a little longer. For pelvic malignancies, it may be advantageous to scan the pelvis in a caudal cranial direction, once again going from the symphysis pubis up to the iliac crest, beginning at the level of the lower symphysis pubis. This technique optimizes visualization of the pelvic vasculature, and so what you do is you're hitting on the pelvic vasculature at a higher degree, and so you can see any vascular abnormalities which may be associated with pelvic masses. Delayed scans can be performed if bladder opacification is desired, and many times it will be, simply because based on all the structures that line the pelvic area, sometimes it's really difficult to discern what is going in which direction, and because of that, bladder opacification will kind of allow you to delineate where the bladder is in relationship to in the female pelvis, where the uterus is, and where the rectum is, and things like that. So sometimes it's very, very interesting just to see the opacification, and especially even for males, because if the prostate has enlarged to the extent that it's encroaching into the bladder, then it will allow you to see that. But also, if you have bladder cancer, it allows you to really see an indentation of the bladder where this mass actually is. So it's very important in most facilities. A spleen survey. This is something that many times gets overlooked, but the spleen survey is used for detecting traumatic injury, infarcts, abscesses, and neoplasms that have to deal with the spleen. Scanner settings are pretty much what our routine abdomen have been: 120 to 140 in kV and 210 to 330 in MA. Oral contrast is optional but not required, usually not needed. Inspiration for our breath hold, and 0.5 to 1 second for the rotation time. Acquisition slice thickness is 5s, but you can recon it in thins. So that you can get NPRs. So kind of important that we acquire NPRs. Pitch is going to be 0.75. Reconstruction slice thickness is going to be 5 millimeters. But once again, if you acquire in 5s, then your NPRs are going to look pretty bad. You're going to probably see this stair-step type atmosphere for your anatomy. So it's better if you acquire them in thins so that you can better utilize your NPR reconstructions. The anatomic coverage is going to be from the dome of the liver to the superior iliac crest. One can't truly be certain where the spleen actually lies, because if you have splenomegaly, just like hepatomegaly, the spleen can extend farther than what you typically would think. So you typically want to utilize this entire anatomic coverage. Contrast is going to be 100 to 150 milliliters at 2 to 3 milliliters per second, leaving us a scan time of 60 to 70 seconds. 70 seconds utilized for slower flow rate or utilizing higher amounts of contrast. And occasionally delayed scans will be needed in equivocal cases. Irregular splenic enhancement is most common in patients with decreased cardiac output. So if you see the splenic enhancement look very weird, it's probably because of some cardiac abnormalities. On occasion, the early enhancement pattern may reveal curvilinear lucencies that mimic a lesion. And so many times, just simply because of the way the spleen actually enhances, it will mimic what a lesion looks like. But a UPJ obstruction, now we're moving back into the renal system. This is used for an indication or evaluation of primary or secondary ureteral pelvic junction obstruction for detection of vessels crossing the UPJ that may be causative or complicate repair. And so basically what you're doing is you're looking for any obstruction in the UPJ, and then you're looking for any vessels that, if there is an obstruction, might be causing this obstruction or complicate your ability to remove this obstruction. Scanner settings are KVP going to be 120 to 140, MA 210 to 330. So you'll notice that this is a quite common number. Oral contrast, there is none. You're going to suspend inspiration or, if necessary, expiration. Rotation time is going to be 0.5 to 1.0 seconds. Acquisition slice thickness is going to be 1.25 to 2.5 millimeters. So notice that we're utilizing thinner slices. And we can actually utilize even thinner slices. Pitch is going to be 1.5. And the reconstruction slice thickness is going to be much the same as what we acquired, 1.25 to 2.5. You can move that up to 3 to 5 millimeters if necessary to facilitate better viewing on packs. However, the 1.25 to 2.5 will allow you to see any type of abnormality or obstruction. So the anatomic coverage is going to be 1 centimeter superior to the main renal arteries and 2 centimeters below the UPJ. So if we decided once again that this is T12 and 11, 10, we don't really know where the kidneys are situated. We assume that this is going to be a kidney here, and then this kidney is going to be right here. But we want to make sure that we're actually acquiring this area very in extremely good fashion. And so we want to go probably about T10, and then actually we could bring this down even farther to about L3, somewhere in that vicinity, to actually cover all of the ureteral pelvic junction. So that's typically what you're wanting. So on this red line, it needs to actually come down slightly, a little bit, so that we actually get all of the pelvic junction. IB contrast is going to be 150 milliliters at 5 milliliters per second. However, you could possibly reduce this due to the fact that you're sending a bolus of saline behind this contrast. So you're scanning initially at 30 seconds, and basically 30 seconds at 5 milliliters per second, you're inject as soon as your contrast injection is done, you automatically go for the arterial phase, so you see rapid enhancement. And then the book actually goes into the thoughts that 10 to 15 minutes should be effective for excretory phase. So somewhere in that vicinity, possibly it could be argued that 5 to 10 minutes would be just as effective, but somewhere in this vicinity is where you want to scan. Okay, so basically comments are clamp nephrostomy tube if there is one present when the patient arrives to distend the renal pelvis for scanning. Considering administering sterile saline via a nephrostomy tube to distend the pelvic system. This may aid in differentiating the ureter from the renal pelvis. And MPRs may be useful. The biggest thing here is that MPRs are going to be what is extremely useful, simply because it allows you to better differentiate things such as the UP. Okay, this is our last protocol, and this is for renal colic. The indication is evaluation of patients with known or suspected renal or ureteral calculi as a cause for acute flank pain. And so someone who is having abdomen pain with a history of renal stone or ureteral stones, this is where they kind of fall in. Scanner settings are going to be the same as what we've already seen. No oral contrast. Respiration can be suspended in inspiration or expiration, but we favor inspiration. Rotation time is much the same, 0.5 to 1 second. Slice thickness is 2.55. However, you scan and thins. Scan thinner. Pitch is going to be 0.75 to 1.5. The reconstruction slice thickness is 5 millimeters. Usually, 5s are a good place to start. And if you were to see a stone and you need smaller, thinner slices, then you can always go back and reform those. The anatomic coverage is usually from the upper pole of the kidneys to the symphysis pubis. And so, once again, this is 12, this is 11, so we're definitely going from the upper poles. We're actually getting all of the kidneys, all the way down to the symphysis pubis. IV contrast, there's no need for IV contrast. So, when calcifications are detected at the ureterovesical junction, or the UVJ, consider rescanning the patient in a prone position to distinguish a mobile stone in the bladder from stones impacted at the UVJ. Another alternative is to scan patients routinely in the prone position. Typically, we don't do the prone position very often, and so this first point about flipping the patient over and scanning in the prone position, that would be a very interesting idea, so that you